Hello, everybody. My name's Ed Pavlik in Lexington, Kentucky. This is my colleague.
Frank Lawton in London, United Kingdom.
We're here today to do another edition of GYN Garage. Today, we're going to look in particular at a paper that was in JAMA. Its title is The Association Between U.S. Drug Prices and Measures of Efficacy for Oncology Drugs Approved by the U.S. Food and Drug Administration from 2015 to 2020. Frank, why don't you take over from here?
Okay, thank you very much, Ed. This is a research letter, as you say, in JAMA Internal Medicine. And essentially, I think this is basically a study of value for money of novel agents in cancer using endpoints of progression-free interval, progression-free survival, and overall survival. They're the two parameters that have been used. And I wondered why, I'll come to it later, but why they just use these parameters, because presumably all pharmaceutical companies must use more parameters than just efficacy to try to market a new drug. In the beginning of the paper, they cite two previous studies looking at cost benefit and efficacy. One showed that there probably was a cost benefit for drugs if you used progression-free survival as the end point, and one paper didn't. Interestingly, the paper that didn't shares the same, or shares one of the authors with the paper that we're discussing. So essentially, as you said, they looked at 224 approved cancer drugs approved by the FDA between the years 2015 and 2020. And they were phase 2 or 3 studies. And as you can see from the table that you just showed, 90% of these were molecular or biological entities, not common and garden cytotoxics, which obviously reflects very much the research into cancer treatments of the day. And interestingly, from a gynecological cancer point of view, only 9 of these 224 drugs were ovarian in origin, and none other gynecological cancers. So the results that they report shows that there is a lower median annual cost when based on overall survival, but not on PFI. They also accept or show that there's a weak correlation between cost and magnitude of benefit, but they don't actually say what the magnitude of benefit is apart from PFI or survival. And rather cynically, which they say that drug prices are what the market will bear. And I think there are a number of points to be made about this paper. Is the idea just to debunk PFI as a measure of efficacy based on price or value for money? I don't know what PFI originally was designed to do, but clearly it is accepted by oncologists and presumably pharmaceutical companies and health as a measure of end. It's an endpoint that is measurable. And I think to sort of say that, well, PFI, there are arguments about PFI and whether it's a surrogate for overall survival, etc. It is used, and I think they really can't get away with that. I think the other problem, of course, is that the drugs or the new drugs that are being developed are basically going to be developed for diseases that are not curable. I mean, if you were designing a new drug for granulosa cell tumors or for germ cell tumors, you probably wouldn't spend a lot of money if you've got a 90% chance of cure with the drugs that you've got. So in essence, these drugs are for patients that are either very niche problems or have essentially incurable disease. So it's no surprise that overall survival is going to be a difficult one to measure, because overall survival is going to be almost the same regardless of what you do. PFI is probably quite important. Does that drug produce a longer progression-free interval, and which of course is very, very important for patients. I think that what they've not looked at is essentially patient acceptability, toxicities, hospital stays, cost of in and out of hospital, adjuvant treatments for infections, etc. They've only looked at the cost of the drug and PFI and overall survival, and I think that's a difficult one. I looked also to find there are only 30 NCI approved drugs in ovarian and peritoneal cancer, and only 10 of them are the traditional cytotoxics. The other 20 are angiogenesis inhibitors, PARP inhibitors, folate, etc. And of the 11 that have been approved since 2018, none of them are straightforward cytotoxics. And also, if you look at the papers, the majority of them have been as maintenance or recurrence. They're not in first-line treatment. So again, you may see overall survival improved, or you may not, depending on the activity of the drug. A paper that has recently come to light is one of comparing the US ideas for regulating drug prices with the European ones. Comparing, now in Europe, we tend to compare standard treatments or the new drugs with standard treatments, or in Britain, the NICE guidelines, cost per additional unit of health. Quality of life. And essentially, if the cost is £30,000 or less, so what's that, about $25,000 or less, and shows an improvement in whatever the outcome is, then it will be accepted by NICE. The headlines that have been in the Financial Times, and I think in probably a lot of other journals as well, have shown that whether or not the market rules, the drug prices of what the market will bear, because I think there are now problems with the way that drugs are being financed in Britain. Essentially what happened is that the pharmaceutical companies agreed to a 2% cap, but with a 2% rise in a price over a year. So if this study that they've been carrying out that we're talking about is from 2015, potentially that's a 10% or 12% increase in price with no change in the drug at all. It's just the price of the drug has gone up. So again, looking back over these data, they don't seem to have taken into account inflation or the cost, the fact that molecular drugs must be much more expensive to get to market than non-molecular drugs. So I think there's quite a number of holes in this paper. And my last point, and I think this is quite interesting. Many years ago, Stephen Fogel from ECOG from New York, produced some data on looking at single agent melphalan versus a 4-drug regimen: cyclophosphamide, hexamethylmelamine, adriamycin, and platinum in ovarian cancer. It was only presented at ASCO as an abstract, and essentially showed that the CR rate was higher for the 4-drug combination, the longer time to progression, but there was no survival difference. And it was buried under data and has only recently come to light as a publication. And those data are still there, that the survival difference is 0, but the progression-free interval and the complete remission rates for the CHAD regimen are the same. Now, if that data were presented according to what we've just been discussing, I suspect multi-agent chemotherapy for ovarian cancer would never get off the ground, because it's shown not to be any more efficient based on what these people say. Than it doesn't improve survival, but it does improve PFI, and PFI is important to patients.
Well, I agree with you. The one thing that you haven't really dwelt on is the kind of costs in the U.S. that the paper gives in its first column. Oh
yeah.
Yeah. So I mean, what we're talking about is annual cost of a median of $196,000 for these drugs, which, if we go down to the table that compares the overall survival with progression-free survival, with overall response rates, you can see that the overall survival table is flat. If you did a regression line on this, it would be horizontal. And it does sort of slope upward for progression-free survival as well as for overall response rates. Now, what this, I think, best relates to is an example that harkens us to what the FDA did with PARP inhibitors just recently. But they said in recurrent ovarian cancer, the PARP inhibitors really were not doing anything. They were not doing anything to prolong life, but they were doing it in a sense that was different from what you've described from alpha and the agent, chemotherapeutic agents, which are all reasonably inexpensive, but not cheap. And the PARP inhibitors for an annual usage in the States, all three of them are above $100,000. Now, granted, just like the paper points out, the differences between insurers and negotiated drug prices means that nobody pays out $100,000, but and in fact their copay is reasonable. But at some point, the insurers say this is too costly, and that's sort of where a lot of these things are going. I'd like to do one other thing here, is to point out a paper in the Wall Street Journal just this week, which is fodder for those of us who don't want to be cynical but become cynical. And that's that really in the United States, there's efforts in line with the Inflation Reduction Act to negotiate Medicare drug pricing, and to do that so that it probably will be 4 years before it's all over. Part of that negotiation is a cap on pricing, but the other part is to hold in line the increases in costs that will occur annually, probably mostly driven by inflation. That those increases in costs were a core issue in the UK, with the increases that had occurred during the years of the pandemic. And I think there's a clawback in those laws that allow some of those increases to be recovered. But the cynical part of this is that in the United States, pharmaceutical houses will raise their prices considerably before the law takes effect. And this will allow them to come in with some buffer, some protection in their eyes against what the Inflation Reduction Act will do to pharmaceutical costs. So we don't really have an answer to, on one hand, what's the only thing to base our conclusions on, overall survival or progression-free survival. But we do have an answer to one thing, that these things in the United States are very, very expensive. Now, is it possible for a physician in the United Kingdom to actually deal with cost, or is that all taking place at an administrative level or a national level? So that's the question I raised for you.
Well, yeah, that's a very good point. The contract, of course, will be with the health authority, not with the individual physician or surgeon. So you can prescribe anything you want, but the patient will have to pay for it if it is not licensed by NICE and because NICE and it's a national health service, all hospitals, there aren't individual, the single provider, NICE, it will say yes or no to a particular regimen or particular innovation. And physicians, the hospitals themselves don't have any say in that price. Of course, if a patient says, "Well, I want this new drug," you can prescribe it off license, but they'll have to pay for it. And it's interesting, Ed, despite the fact that the headline, the opening line of the paper says that America pays the highest per drug, but doesn't have a commensurate good survival for cancer. How many patients, certainly from Great Britain, when they hear about an innovative treatment in their particular cancer or their particular problem, will crowdfund to get money to try to get their friend or their patient or their loved one across to America to try out these drugs? And I think that's an important thing that this paper's missed. That PFI is important to the patient. It may not actually stand up to robust costing and other things like that, and it may well be that it doesn't affect overall survival. But a patient, as you know and I know, will hang on to almost everything if they feel that there is a chance. And I think that's the problem with this paper. I think to dismiss PFI, if you like, or not dismiss it, but just to say that it's not a surrogate for survival. No, it isn't. but it offers hope and expectations, I think, to patients and their relatives, and presumably to their doctors as well. Oh, you've gone.
I agree with you, Frank. The
Yeah.
one thing that comes out of all this too is that in America we don't travel to Great Britain, but we do travel to Mexico for seeking out things that aren't available in this country, and also seeking them out without crowdfunding because they're much less expensive. I think the other thing, though, that comes out of the PARP inhibitor withdrawal by the FDA for recurrent ovarian cancer is that the numbers that were presented to say that these should go to market did not measure at all the interval that people who could not continue on a PARP inhibitor.
Yes. Yeah.
So, that's an element too that would be very helpful in a progression-free survival setting, where that counted in terms not only of progression-free survival, but time till retraction.
Yes.
Plotted the same way.
Yeah, I think that, you see, that would never happen in the United Kingdom. The PARP inhibitors would never have got to market, because they would have to have shown a reduction in toxicity or acceptable toxicity or an improvement in whatever outcome that is being measured, of which there are numerous. And I think that's probably the difference between the European system and the American system. The FDA will approve, I mean, they must use toxicity data, but essentially the way it seems to me is if there is an improved efficacy, regardless of the price, then it can be marketed. And that's not the case in Europe and Great Britain, certainly.
Well, very good, Frank. Let's wrap this up by saying that these things are expensive, but still needed, and it's hard to make decisions for ourselves when we have resources. It's hard to make decisions for people without resources, and luckily we're not government officials where we have to face that difficulty.
Yes, somebody else can do that.
Very good. Well, we'll see you again in a month.
Yeah, see you in a month. Cheerio. Bye-bye now.